Hi, welcome everyone. So nice to see so many of you here. So as you heard, I work at the Sahlgrenska University Hospital, and I don't know if many of you are aware, but the Sahlgrenska University Hospital and Västra Götalandsregionen, so the region that the hospital is a part of, have been working really hard lately to improve our capabilities in advanced analytics and AI. We have an in-house cluster of 2 NVIDIA DGX A100s. We have a team dedicated to working on our AI computational cluster platform, and many researchers, clinical researchers, and in-house research teams using that cluster. The work that I'm presenting today has been a collaborative effort between my team, the AI Competence Center at Sahlgrenska University Hospital, and the Västra Götalandsregionen, so the higher regional level, and the data analytics team there. It is a truth universally acknowledged that healthcare is an extremely unevenly distributed resource. If you think about it, it makes a lot of sense. Most of us go about our day-to-day lives not having to go to the hospital, not having to think about doctors. But there is a small minority who need a lot of help to manage their health. This small minority we call high-needs, high-cost patients. This is a term from the academic literature, a little clunky, but I'll keep using it today just to keep us aligned with what the others are doing. If you think about it, you might have an idea of who might be part of this group. For example, if you know someone's going through cancer treatment, they're probably needing quite a lot of help from the healthcare sector right now to manage their health. So we might have an intuition about something, about the individuals that are part of this group, but we actually don't really have a good sense of who they are as a whole. Because it's not just cancer patients, or it's not just elderly patients. There are all kinds of patients in this group. And given how much care these individuals need, and how much resources they consume, it would be better if we better understood them to be able to then better serve them down the line. So we wanted to see if we could dig in a little deeper into this group of high-needs, high-cost patients, and we did this by trying to answer 3 very specific questions. First question is, do we even have this kind of high-needs, high-cost patient group at Västra Götalandsregionen? The instinct was probably, yeah, it exists pretty much everywhere else, but we've never looked at it, so we had to start there. Then if we are able to find this type of group, who are they? What can we know about them? And finally, what can we do to help them? How can we better serve them? This story starts like all good data stories, with data. So we combined data from all of the 17 public hospitals in Västra Götalandsregionen. This data contained all the information about every encounter that any patient in the region had had with any hospital and any cost associated with those visits. And we started with the first question. Is there even a group high-needs, high-cost patients in Västra Götalandsregionen? We, again, started looking at the data. First, just some basic numbers. In 1 year, 2019, about 580,000 patients visited at least one of the hospitals in Västra Götalandsregionen at least once. And these are now adult patients. And this care corresponded to 22.6 billion krona. If we take all of these patients and we put them on a line according to how much resources they consumed during that year, and we split this line into equally sized chunks so that each chunk represents 5% of this population, we get something like this. On the y-axis is this particular bar's consumption of the healthcare resources. And we see that the last bar, 95th percentile to 100th percentile, corresponds to 46% of the total hospital resources for adult patients in 2019. This group, the blue bar, the colors are not super clear here, but this is a blue bar, and those are the ones we're calling high-needs, high-cost patients. If we look at the little numbers associated with this group, it's about 29,000 patients in 2019, and their care corresponds to about 10.6 billion krona. So just to emphasize, these 5% of patients between 95th and 100th percentile consume almost as much care as the other 95% of patients combined. So we definitely want to know more about this group. One of the first things we asked was, this group, are they the same patients every year, or does that change? Because depending on the answer to that, we might want to look at it slightly differently. What we did is we built a graph, a so-called alluvial diagram, and here the gray represents patients who for that year are not high needs high cost patients, and the blue represents patients who for that year are high needs high cost patients. And we looked at patient flows over the years from group to group, and what we see is I've cut out a really long gray bar here, which is just patients who never end up being high needs high cost patients. So you're only seeing the data for the patients who were in this group at least once over this 5-year period. But what we're seeing is that about 65% of patients are in the group for the first time. They haven't been high needs high cost patients before. And then about 35 to 40% are coming back to this group, either from the previous year or for having been away from this group, returning again. And there's a small set of patients who persist in this group year over year over year. This is a very interesting group. So now we wanted to know a little bit more about them. Who are they? If you ask any clinician, anybody who's worked with patients ever, who do you think needs most healthcare resources? I will almost guarantee that one of the first things that they think of is patients who are a little older. Absolutely, that is the case. These patients, on average, are older than our other 95% of patients. So here in these plots, the gray line is always the non-high needs high cost patients, and the blue line is the high needs high cost patients. On average, they are older, but I also want to emphasize that 40% of these patients are working age, under the age of 65. So it's not exclusively older patients. It is also younger people in there. What else can we know about them? Well, they come to the hospital more often. They also, when they come to the hospital, they meet with more specialties. You and I, when we go to the hospital, we maybe go there for one thing. You maybe have a heart condition and you see your cardiologist, or you have a diabetes and you see someone to manage that. But these patients might go to see a cardiologist, a rheumatologist, and a neurologist. They also have more diagnoses than the non-high needs high cost patient group. And this places us in a bit of a bind, a dilemma, because the healthcare sector, we historically are not good at looking at things that are complex in this way. What we historically do is we slice the data into very beautiful, clean silos. We look at one specialty at a time, one organization at a time, one diagnosis at a time even. And I would argue that this works great for the 95% of the patients who are not high needs, high cost, because they might have just one diagnosis. They come just to one hospital to meet with just one specialty. But this high needs, high cost group, their condition, they're so clinically complex that their condition requires more involvement from more specialties. And it's not that one day you are a cardiology patient seeing a cardiology specialist and one day you are a neurology patient seeing a neurology specialist. The patient is both patients at the same time, they're just seen by different specialties. So we cannot really slice and dice these patients into these very neat silos that we like to use. So, wow, okay, a high dimensional problem. I wonder what we could do about this. We did exactly what anybody in this room would do. We went to clustering. We built some features for clustering, some demographic stuff. We thought a lot about diagnosis. If you've ever worked with health data, you maybe know that there's a lot of diagnoses out there, like potential diagnosis, more than 10,000 easily. And many of them are extremely rare. So you don't really, if you try to just one-hit encode diagnosis, you get an extremely sparse matrix, which is not optimal. We debated doing some kind of dimensionality reduction on this very sparse matrix, but in the end, instead, we decided to, in order to maximize the explainability of our results, we decided to build some diagnosis groups that stem from the literature. For example, this Charlson Comorbidity Index, which has to do with chronic conditions, and we complemented that with some types of diagnoses that were not present in the Charlson Comorbidity Index. We also included information about whether the patient had needed emergency room in the year that we were looking at, or if they needed dialysis. Importantly, I think, besides the need of ER and dialysis, we had no information about the cost these patients incurred, the amount of visits they had, the amount of time they spent at the hospital, because we felt that it was more important to understand the needs of this patient group rather than focus on the cost side, even if that was how we figured out who belonged in this group. But now we wanted to understand who are they as patients and what do they need. So for the clustering, we tried a couple of different methods. Density-based methods seem to be working best for this specific data set. We ended up going with hierarchical DB scan. Ended up with Gower as the distance metric. We have continuous and categorical variables. It seemed, fitting. And then we finally visualized these clusters using UMAP. And we got this picture that I'm showing you here. It's pretty. There's like blobs, and the blobs are of different colors. But again, we come to this realization that in the organization where we're at, and in the branch that we're at, we're not really used to looking at things like this. It's a little confusing. If we just went around the organization showing a UMAP plot saying, this is your patients who need a lot of care, we'd get a lot of blank stares. So in order to facilitate interacting and working with these results with stakeholders, we also built a little Shiny app to help us dig deeper into these clusters. I'm going to show you some screen caps of the Shiny app. I was wanting to show it to you live, but I was told that unfortunately no live demos that require internet today. So here we have the same UMAP that you saw, but this is now done with Plotly so that it's interactive. You can hover over each point and you can see which cluster it is. You can also use the legend to either remove traces or isolate traces if you want to focus on seeing which patients are where. We had another view where on the left we have a tree map. We've taken all of the clusters that we got. They came back with like numbers like cluster 0, cluster 1, as they do. And we tried to convert them to clinically meaningful names based on the features that were most prevalent in that cluster that were most separating that cluster. So on the left, we have a tree map of these clusters with the cluster names, and it's scaled to the number of patients in that cluster. And on the right, you can see the distributions of the features that went into that cluster. And now we're showing it so that the light blue is the active cluster that you've selected, and the gray is the cluster is the whole group of high needs, high cost patients. I think you might have quickly seen you can also scale the tree map to cost if you want. But this was enormously helpful also for us to see what actually separates these groups. And one thing that we found is that we actually have kind of super groups in these clusters. So for example, and that's what we've shown in the colors in the tree map. So for example, all the cancer patients, or the groups that are separated by it's being overwhelmingly cancer patients, they are now shown in black. Or the purple groups are groups that have almost no or fully no chronic conditions, but that ended up coming to the hospital because of some kind of trauma or some kind of accident. And in another tab, we have information about the cost associated with these patients in these clusters. I want to point out that the y-axis is logarithmic, so the spread is actually quite huge. But this allows people to also understand slightly better how the cost within these smaller clusters is distributed. And for our colleagues, analysts, who are used to looking at things in numerical format and maybe not super comfortable with just looking at graphs of things, we have included all of the summary data in a tabular format with highlighting showing which cells are the ones that mostly separate this cluster from the other clusters so that they can get the exact precision that the little hearts so desire. Finally, to the big question, what can we do to help these patients? What an excellent question. Boy, do I wish I had a really good answer for you guys. Because the real answer is it's a little difficult. It's a little difficult, partially because what I said earlier is our branch, our organizations, they're not used to this type of way of looking at the data. They're not used to breaking the silos in which we budget and in which we organize. They're not used to seeing the patient as the clinically complex whole on a group level, not just on individual level. So it seems that in order to make effective change happen, we also need to learn some new ways of behavior, and that's absolutely a work in progress, at least in my organization. What we're hoping we would be able to do is we're hoping we would be able to talk more deeply with clinicians about these clusters, dig deeper into them, and understand them better. How do these clusters present clinically? Is there any way we could predict whether someone would end up being a high-needs, high-cost patient soon? Is there anything we could do to prevent someone from becoming a high-needs, high-cost patient? Because I want to be very clear, it's not fun to be in this group. If you could ask anybody who spends a lot of time at the hospital, would you rather be healthy and living your life? I can guarantee they would rather do that. So I think as a healthcare sector, our duty is to try to enable that if we only can. And there's some hope. There are some potential subgroups or clusters in this whole patient group that might be more actionable than others. So for example, if we take cancer patients, maybe less actionable. Cancer treatment is expensive, but we're happy to pay it because it means that you get many, many more years to live. You can make a full recovery. You can go back to your family and your loved ones. Maybe not a lot we can do there. On the other hand, functional disorders. Functional disorder is when you feel terrible, you have a lot of symptoms, and the doctors just can't find anything wrong with you. They can't find a diagnosis that would fit. They can't find a source for your discomfort. It would be important that we would be able to detect these high functional disorders as early on as possible, as the treatment is very different depending on whether it's a functional disorder or whether it's something that we can diagnose and we have a pill for. So we're hopeful. We're hopeful that there's something that we can do here, but we don't know exactly how we're able to bring the organization together to do that. But I still think we need to try. And that's what we're doing. That's what we're continuing to do. If this type of question and problem seems appealing to you, I want to shout out quickly that we'll be hiring soon more people to our ML Ops and productization team. So come talk to me. I'll let you know more about that. And I want to thank the people who have been working on this project. Lisa, Anna, Victoria, they're all here today. They have been the technical brain in this project. Also Tuve Mattiasson, who has helped us enormously in understanding what type of segmentation can be actionable and useful for our stakeholders. Thank you also to Vinnova. This was a part of a larger Vinnova-funded project called Information During Care, where we've been working together with Region Västmanland to better understand this patient group and also to raise the understanding of it within the Swedish healthcare sector in general. Thank you.
Wow, Julia, thank you so much for that presentation, and that's truly incredible to hear what you're doing for VGR, and so important to try to incorporate artificial intelligence into the healthcare sector. We do have some time for some questions, so do think about your very best questions. Before that, I'm going to ask one though. I was just wondering, how are you sharing this type of work and this competence throughout our nation? Because obviously this applies to more regions in Sweden.
Absolutely. That's also a work in progress to some extent. We're hoping to be able to, for example, publicize the Signy app so that anybody can go in there and look at this data on an aggregate level to better understand this, hoping that it might spur more research and more interest. And of course, we'll talk anybody's ear off who listen. but at the same time, like I said, this is a little challenging because this is not the type of analysis people are used to seeing. So they might not be fully comfortable with what can we do about it.
Right. Okay, good to hear that that's happening. Yeah, with that said, I think we can start with questions in the room. I think the gentleman in orange over there. Yeah.
Is this on? Yes. Thank you very much for a really interesting talk. One of the conclusions I would seem to draw from your talk is that if you are one of the patients in this group, you shouldn't assume that the healthcare system is going to join the dots for you between different services and different specialties. You have to sort of become your own project manager and work out exactly those connections yourself. Is there a way in the future of having that kind of holistic project manager for an individual patient, either as in human form or maybe, for example, using some kind of AI assistant or project manager?
That's an excellent question that goes more deeply into the procedure of the healthcare sector than my engineering brain is necessarily able to answer at this point. I do think this would be, for example, an excellent patient group, or maybe some of these segments might be excellent candidates for this kind of care and extra attention, because if we can prevent someone from ending up in the hospital for 2 weeks, that's going to pay, I don't know, I think this might pay for like someone's salary for the better part of a year or something. Like the way the prevention is so much more effective than the care, the more intensive care is incredibly clear in this patient group specifically.
Thank you.
But no exact answer to your question, unfortunately.
All right, let's continue on with the person behind this pillar over there, maybe. Lucky I saw you behind that pillar.
Thank you for an excellent talk. I was curious about, regarding the first question again, how are you working, or are you working with like open source, or not necessarily open source, but would it be possible to apply your methodology in other regions? And is it going to happen?
Yeah, so we're publicly funded. You are all paying for us. So our thinking is everything that we write code-wise, we're happy to share. We're trying to get more regions interested in this. Like Lucas mentioned in the beginning, I have founded a network also for all the data scientists working in the public healthcare sector in Sweden, so that we're able to share code bases, share knowledge, so that we're not allowed, the thing is we're not allowed to share data, so we cannot come into someone else's region and do this analysis for them, but we can absolutely, and we're very willing to help them do that at their place.
Right. Let's continue on with this person over here. Yeah.
Hi, and thank you for the talk. I was wondering if you could give me some insights about the criteria that led you to choose DBScan. What is a good cluster, and how did you define good clustering?
You mean how we determined what the clusters were?
How did you determine what good clusters were?
How is determined what name we put on the clusters?
You mentioned you did several clustering algorithms,
Yeah.
and you chose DBScan.
Yeah.
How did you evaluate the results of those clustering algorithms?
We mainly tried to look at the resulting clusters, whether they felt cohesive and understandable, and how much noise there was in the result. We didn't, between the different methods, we didn't use any specific metric. Within the methods, we were using a silhouette score, I think, to look at like different parameters and how well those performed. But between the different methods, we just saw that, for example, k-means, well, it tends to give you fairly uniformly sized clusters, and we kind of knew that that wasn't the case, whereas HDBScan was able to give us these more organically sized clusters that were also very strongly clinically relevant. So more vibes than maths, if I can say that.
Thank you.
Great. Maybe we can take this question over here.
Yes, thank you very much for this. Interesting. I have a question Sorry. I have a question. This, as you say, you can be used to prevent and prognosticise, you know, what kind of diseases do we have. But there's also an element of predictive power in this. Have you been looking at that and thinking about, you know, how can we predict, you know, changes in demography and so forth, changes in, I'm thinking about, you know, we have people from different regions of the world coming to Sweden. Maybe the disease pictures are looking different, and maybe you can plan for that, saying, okay, maybe this will happen in the future. We need to prep the hospitals for managing this and so forth. Are you thinking about those aspects as well?
That's an excellent question. At the moment, I think in the region we have traditional statisticians looking at these questions using very traditional statistical methods. I'm not working on those questions myself, so I don't know if they're planning on going more multidimensional with that, but we're definitely in talks with them to share our tools and knowledge with them so that they at least have those tools in case they deem that appropriate approach.
Great. Yeah, maybe I'm thinking one last question right now, and then we have to move on. But let's take over here.
Hi, Julia. We were at Alison Cohen's talk a little earlier, and she was discussing working with AI and human trafficking and the importance of getting the perspective of human trafficking victims and talking with them. And I'm wondering, did you do something similar? Have you had discussions or any insights from people who fall into these categories?
Not yet. I think as soon as we better understand exactly who these patients are, we would want to also fold them into this discussion so that it's not just an engineer with a PhD going, this is how healthcare should work, but it's more close to the individual. But these results are very fresh. This is our first take at this. So we haven't yet been able to say, yes, this is exactly the patient organization, for example, that we want to reach out to in order to have this dialogue. But I think it's very important that the patients are a part of this. Because as you saw, these patients spend probably more time at the hospital than I do. My office is outside of the hospital. So they definitely deserve a say. If we don't have any time for more questions now, feel free to find me or Lisa, Anna, or Victoria at any of the breaks. They would love to answer all of your questions, especially on the technical stuff.
Great. Thank you for all the wonderful questions. And Julia, thank you so much for a wonderful presentation.
Thank you.